Yeah, thanks again, Axel. And you're absolutely right. This is kind of like a part of the field that we were involved in, but not necessarily we had a lot of opportunity to talk about anything because very limited data coming forward. Anyway, I'll start by discussing what the diseases and the new perception on the biliary cancers. We'll talk about chemotherapy, targeted biologic therapies, and of course, if any role for checkpoint inhibitors. In regard to the disease itself, as you recall, historically and even till today, the way we delineated diseases is totally anatomical. Inside the liver, intrahepatic cholangiocarcinoma. In the ducts outside the liver, extrahepatic cholangiocarcinoma. Of course, in the gallbladder cancer. Nowadays, I think the delineation probably still apply, but more importantly, however, the genetic makeup of the tumor clearly is differentiating them per se. And as such, for example, and this might be in the practical, in your clinic, you're going to see that situation. Let's say you get an extrahepatic cholangiocarcinoma as delineated as such, but right at the edge, but it has, for example, an IDH1 mutation. Would I sweat and say, no, this is not intrahepatic? Of course not. This is clearly a continuum of the same thing, and as such, the genetics is going to make a lot of difference and a lot of applicability in regard to what the diseases are. With this said, I'll jump on to chemotherapy only because this is where things started, and I'll go back to the more detailed discussion of the biology and targeted biological drugs. And we all know that the nice work that was reported by our colleague Dr. Fali from the UK in the ABC02 study, if anything, showed that gemcitabine plus cisplatin has an improvement in outcome compared to gemcitabine, with a survival, as you can see, at 11.7 months versus 8.1 for the gemcitabine. That led kind of to the acceptance. I wouldn't say approval because there was no approval to be done because these were drugs already are in the market, even in generic forms. And as such, it's not like there was any approval waited, but we all kind of accepted that gemcitabine and cisplatin become the standard of care therapy for biliary cancer across the board, without any delineation or differentiation regard between extra, intrahepatic, or gallbladder cancer. It's just kind of, one size fits all. Another important component of the ABC02, it showed also an improvement in regard to progression-free survival, as you can see, over 8 months for the gemcitabine cisplatin versus 5 months for the gemcitabine. Now, this component, even though it's positive and we like to see it as well, it carries a little bit of an important interpretation that, again, we're going to see a little bit in practical world over here, because in the UK, the way the practice of oncology goes, not necessarily only for biliary cancers, but in general here in the US, we scan every about 2 months or so, give and take. Over there, they scan a little bit longer time, i.e. about 3 months or so. And as you can imagine, when you're measuring PFS, if you can't see it on camera, it didn't happen, because PFS will depend a lot on the CAT scan. And as such, if you're taking a longer time between CAT scans, by definition, your PFS is going to go longer than it's supposed to be. So this is an important technical part, and many of us who are involved in the development of research for the disease, having the reference being ABC02 will bring a little bit of a perplexity in regard to what is really the true PFS of the gemcitabine plus cisplatin. Nonetheless, we'll pause on that question and we'll carry on. Nice work that's relatively newer that was just reported in JAMA Oncology a few months ago by Dr. Rashna Ashraf, if anything, on gemcitabine, cisplatin, and nab-paclitaxel. The combination appears to be in this phase 2 trial rather intriguing, with, as we can see here, quite a bit of a response, which nice to see on the waterfall plot. And of course, within the context of a phase 2 trial, the PFS was 11.8 months, and the overall survival was 19.2 months. And of course, here, with all bells and whistles, we cannot really comment on a phase 2 trial in regard to the outcomes, because this is kind of like, the test phase within a very highly select population. It's not really thrown in yet into a phase 3 trial in the real world to really understand better what's going on. Nonetheless, that data actually led to an agreement for the study to move forward to a phase 3 trial, to a phase 3 trial, and this is I proudly and humbly, I'm happy to say that under my direction as chair of the Hepatobiliary Task Force for the NCI, we approved that, and it went to the GI Steering Committee, which is co-led by Dr. Grothy, and it was approved to move on. So currently, there's a clinical trial of GemCis nab-paclitaxel versus GemCis, which is available and open at multiple sites. And if you are part of a cooperative group, even if you are in community, but you are part of a certain cooperative group, by all means, we encourage you to open that study and try to help continue the accrual on it and see where it takes us. Now, with this said, another piece of news that we all heard at ASCO this year is the ABC06 study, which is actually a second-line treatment of FOLFOX in patients with biliary cancers. And if anything, it was a positive study. It was reported by Dr. Lamarca, 6.2 months for the FOLFOX versus besapotequerel alone for the second arm, 5.3 months. If anything, there was one delineation of the study that really showed a further outcome based on platinum sensitivity and resistance and refractory. And these were kind of like man-made definitions. It's not like we really we will use them or interpret them the same way. But by definition, please do remember that patients on the ABC02, and this is the standard, especially in the UK, we don't use that standard over here in general. Patients take only 6 months of therapy on the ABC02, regardless of the outcome, even if they're doing great, will stop therapy. And these are technically the platinum-sensitive patients who did great on the ABC02, and now they need second line per se. On the other hand, the platinum-resistant patients are the one actually who are to progress while on therapy on the GemCis, and the platinum refractory are the one that actually will progress within 3 months after the discontinuation of the GemCis. Regardless of the definitions, at the bottom it shows that regardless of which patients we're talking about, the outcome is positive, and if anything, it shows the value of the FOLFOX therapy in that regard. However, very important point here to delineate, and to be fair, this was not yet brought up by by Dr. Lamarca herself or by her colleagues, and we're waiting for the manuscript to see how this is going to delineate itself. But is the FOLFOX therapy nothing more just a continuation of the GemCis, for example, that we already give in the US until progression or intolerance, i.e. it's not like but a continuation of the platinum compounds? Really, we don't have that delineation yet clear, even though, interestingly, the platinum sensitive suggests that in that regard, because we have the GemCis sensitivity followed by the FOLFOX afterwards that shows relatively a better improved outcome compared to if they were resistant or refractory. We'll leave that debate for now. And by the way, another component before I carry on to the targeted is like, ultimately, will there be a difference between the different delineated diseases, as we just mentioned, extrahepatic, intrahepatic, gallbladder in regard to the chemotherapy, or is it going to be like one size fits all? Interestingly, this does probably remain a question in regard to the chemotherapy arena, but when it comes to the targeted therapies, is probably better delineated, if at all, probably almost all delineated. This is one example of work that we have done at Sloan Kettering, but there's plenty of other great examples from different groups that looked into the different genetic mutations that we can see with those diseases. And if anything, we brought up in our work what we call the mutual exclusivity of genetic alterations, i.e., for example, if a intrahepatic cholangiocarcinoma is a IDH1 mutation, cannot have FGFR2 mutation or a fusion, or vice versa. If it's an FGFR2, it won't get an IDH1. So there's a certain mutual exclusivity that we're trying to understand better as we learn and move forward with the disease. Now, another important component, this is very important, especially for patients. Who are those patients? They are really the minimum number of patients. At best, we can say that maybe about maximum 15% of the patients might have a mutation of an IDH1, and there's a variation of up and down this number, like vary between 13 even up to 20 sometimes. And on the other hand, in regard to the FGFR2, again it varies, but the fusion is kind of like ranging in the about 5%, even though there have been numbers higher than that, about 10% per se. With this said, what's IDH1? So we all have IDH1, and if anything, if it's mutated, it will kind of like take a little bit of a side road, moving things into 2-hydroxyglutarate, which is actually an oncogenic driver, and as such, the tumors will start to grow and replicate without any limitation per se. So this has been actually quite intriguing. A lot of focus was in the beginning on GBM. However, we kind of like at Sloan Kettering, we kind of knew the potential value for an IDH1 mutation, and we kind of, joined in with the neurology group on their own study, and then we kind of expanded further the work into a cholangiocarcinoma larger cohort. As you can see, this was reported again earlier this year. I should update the reference because now it's in the Lancet Hepatology Oncology, Hepatology-Gastroenterology Lancet, and it shows clearly that there are certain robust responses in regard to the therapy. Ironically, this kind of carried on to a phase 3 trial. This happened actually here in Chicago. Kind of like while we were at ASCO, I made an argument to the sponsor that we need to push into a phase 3 trial, which probably we did. And if anything, it's a randomized phase 3 trial of patients to get in second line the AG120, which is now has a generic name ivosidenib, versus placebo, but with a allowed crossover that was kind of argued why patients have mutation, why not to give them a chance for the drug. Anyway, the trial, all what I can tell you is exactly what was officially reported already in a press release from the sponsor. It says that the announced randomized phase 3 trial of the ivosidenib demonstrated statistically significant improvement in progression-free survival compared to placebo, which is, of course, the primary endpoint. The study was designed with 96% power to detect hazard ratio of 0.5 PFS with one-sided alpha of 0.025, and the full analysis will be presented. I proudly will present that at ESMO in the presidential symposium on Monday, the September 30. So we'll just have to wait until then, and we'll hear more about the data. With this said, another target which is really of value is FGFR2 that happen in different fusions. Nonetheless, there's a lot of intrigue and interest in regard to the FGFR gene fusion and potential targets. And one of the best quoted reference is the one that our colleague, Dr. Javli from MD Anderson, that we were all part of as a multi-cooperative effort with different institutions. As you can see here, it shows that BGG398 actually shows an impressive response, and of course, suggestion that maybe we should carry on further with that. Interestingly, and this is an important nice piece that was written by our colleague Dr. Goyal from MGH about what happens for patients if they were to really stop responding to an FGFR2. And I'm putting this work specifically here because it's applicable to BGG398. These patients were treated with BGG398, and they did a nice piece of work, which really we give them a lot of credit for. Actually, as patient quote-unquote progressed, or even, let's say, sadly, they passed away, they did actually stat autopsies on patients, and they took like snippets of disease tissue from the liver at different sites, and if anything, they found that the alteration of the genetics do occur, and if anything, the V564F will alter into other mutations, and maybe it will be the one that's driving the whole component as being like probably at the driver or gatekeeper mutation. If anything, at the moment, Lipica and with the help of a mathematician and proudly agreed to kind of what I suggested, that probably there is a certain mathematical chaotic phenomenon happening over here that we need to delineate further. So this is work that's ongoing as we speak per se. With this said, however, the landscape for the FGF, as I mentioned, is really pretty broad. We have the BGJ398, we have the Insight 54828, we have the TAS 120, we all know about it, and there was an argument that because it's not reversible, it might be a little bit more potent. We have the ARQ087, we have the DB1347. At least two of them many of us are involved in. I think Dr. Bikai Saab is leading on the Insight, and Dr. Javli and myself were leading on the BGJ in phase 3 trial in first-line setting with chemotherapy. And in addition to that, many others are moving into different directions. Some of the sponsors are favoring going at a target specific for a specific mutational change or for a certain line of therapy, while others are taking a little bit of a broader perspective or a value of even treating patients with that mutation with the presumption that it might occur at some point in time. So we just have to wait to see where this rather very busy field at the moment without a clear answer will take us and take it from there. With this said, checkpoint inhibitors, yes, they were in the discussion as well, and at least they were looked at. This is nice work from Dr. Bank from Seoul, Korea, that looked into the pembrolizumab in patients with bile duct cancer, and if anything, it's remained a very limited cohort of patients, as we can see over here, mainly biliary tract and less for gallbladder. And if anything, the data, again, similar to what we have seen with other checkpoint inhibitors, showing a response rate in the 17% range, but remember, please, within the context of a limited phase 1b study. Nonetheless, there is a certain intriguing point about if this is to be carried further. At this point in time, some of the approaches being considered is same like in HCC, is a combination therapy, quote unquote, with either chemotherapeutic agent or one of those new targeted agents that we just spoke about, targeting one of the mutations like IDH1 or FGFR2, but also another effort that we have at least done in a early look preemptively at Memorial is to use the abscopal effect that actually our group have described beforehand and try to see if a radiation approach followed by Pembro will be, or Nivo, or your choice of an NTPD1 will be valuable in regard to intrahepatic cholangiocarcinoma. So it's nice to see at least that we have a lot of interest in that regard. One more thing I'd like to comment on, which I don't have slides on, is let me comment first on the MSI high. This was just put in here just as a reminder that we all agree that we do the MSI high approach treatment with checkpoint inhibitors. The chance, by the way, for patients with a biliary tumor / cholangiocarcinoma to have an MSI high is probably about 4% at best. Nonetheless, it could be one of the reasons you can get the argument to get the genetic analyses that, of course, will open the door for other mutations per se. With this said, to go back to mutations, another thing which is very early in the game, but something to keep focus on, is HER2, especially in gallbladder cancer. And at the moment, there's kind of quite a bit of interest in regard to treating patients with a anti-HER2 if they had gallbladder cancer and the mutation. Very early in the game, but nonetheless, I'm sure we'll see clinical trials coming up in that regard. With this said, I conclude that gemcitabine cisplatin versus gemcitabine improves survival and remain the standard of care and the default, despite the limitations that I kind of brought up. Gemcitabine cisplatin nab-paclitaxel is under evaluation. Again, please, I urge you to make sure that if you have access to the trial or your interest, please to open that study. FOLFOX as a possible second-line treatment, I would say there's quite a bit of questions still need to be answered. We'll wait for the manuscript and see if any further delineation of that will be applicable. If anything, the bundling of the biliary cancer, I think we are coming to an agreement that is not valid anymore, especially when it comes to the genetic mutations. And the IDH1, as I mentioned, has a positive outcome results. We are still embargoed and will present this in a few weeks in Barcelona. The anti-FGFR offer potential therapeutic options, and we have many of the clinical trials that are ongoing or planned, and we'll wait to see those. And of course, immunotherapy work, as I mentioned, is underway from different perspectives, as single agent, combination, or even with different approaches. So I'll pause here. Thank you very much for listening.